Hello and welcome to the ImpediMed webinar series. My name is Joanne Yao and I am the Vice President of Marketing with ImpediMed. Today's webinar is titled The PREVENT Trial, how the largest randomized trial to assess lymphedema prevention will impact patient care today and for years to come. On the heels of October Breast Cancer Awareness Month, we want to recognize the patients, caregivers, researchers, and advocates working to improve the lives of millions of breast cancer patients worldwide. ImpediMed has a long history in breast cancer-related lymphedema care with both novel technology and clinical studies such as the PREVENT trial. Today, you will hear from two panelists who were involved in the PREVENT trial from the beginning and are instrumental to innovating an early intervention model of care to reduce the impact of chronic lymphedema on breast cancer patients and survivors. Dr. Chirag Shah, co-director of the Comprehensive Breast Program, Director of Breast Radiation Oncology, and Director of Clinical Research in the Department of Radiation Oncology at Cleveland Clinic, and Louise Koelmeyer, PhD, occupational therapist and lymphedema therapist, Director and Senior Lecturer in the Australian Lymphedema Education, Research and Treatment Program, also known as the ALERT program, at Macquarie University in Australia. We look forward to an engaging webinar today and welcome your questions. You may participate by submitting questions via the Q&A icon on your screen. We will answer as many questions as possible during the next hour, and we'll follow up on any questions that we are not able to address live. We're also happy to offer certificates of completion for your participation in this webinar upon request. To request a certificate, you may either respond to your registration email confirmation, email us at info@impedimed.com, or contact your local ImpediMed representative. All webinars are available for replay approximately 1 week following the event. You may find them on ImpediMed's Oncology YouTube channel and make sure to subscribe while you're there. Now I would like to invite Dr. Shah and Louise to join me on video. Hi, Dr. Shah. Hi, Louise. Thank you for joining me. It's great to see you.
Good to see you as well.
Let's go ahead and start with some quick introductions before we get into the content of the webinar. So Dr. Shah, I'd like to invite you to go first with a quick introduction about who you are and your current practice.
Sure. So I'm Chirag Shah. I'm a radiation oncologist by specialty. I work at the Cleveland Clinic where I serve as the co-director of the breast program and direct the breast radiation program. On the lymphedema side, I was the co-investigator of the PREVENT trial and have been doing bioimpedance research for about 10 years now.
Thank you. And Louise.
Hi, everyone. I'm Louise Koelmeyer. I'm an occupational therapist and lymphedema therapist. But as you've said, Joanne, I'm the director of the ALERT program at Macquarie University. And we were fortunate to be the Australian site of the PREVENT study, where we recruited 450 of the 1,200 women. So I'm an academic position now involved in research and teaching, but I still maintain a clinical role to keep me grounded and real. And I love working with patients, and I'm passionate about this model of care that we're talking about today.
Thank you, Louise. Well, we are so lucky to have both of you joining the call. We're going to have a really interesting conversation today, and really for the audience, something unlike you've seen from us before, where we're going to dive into the PREVENT trial with two people who were there from the beginning. I think before we dive in, though, we want to acknowledge the huge group of people, both investigators and patients, who were involved in this study. So, Louise, if I might turn it over to you to quickly acknowledge the principal investigator and others that were involved.
Sure, Joanne, thank you. I'd like to just acknowledge Dr. Sheila Reidner, who was the principal investigator of this study from Vanderbilt University. I personally learned a lot from Sheila involved in leading this study and really took my research skills to an exponential level. But I think also the whole team, it was a multi-center, multi-site trial, and you can see all of the various centers on the slide here. So to all of those who supported the trial throughout the 6-year period that it was conducted, and also a special thank you to the women who were invited and participated in the trial to have their commitment for a 3-year period was fantastic and has given us the insights that we're able to share with everyone today.
Thank you so much. And Dr. Shah, do you have anything you'd like to add?
No, I really just like to echo kind of Louise's comments that this is really a testament to Dr. Ridner and all the patients who were kind enough to support this study. And we're really excited to be able to kind of use those results in our clinical practices now.
Absolutely. The amazing amount of dedication to completing a trial with 1,200 patients enrolled and 3-year follow-up. Now, we have an opportunity to take a look back. If you guys will kind of put yourselves back almost 8 years ago, if I'm correct, on when kind of the PREVENT trial was getting started and why it was necessary. I mean, why did you and your colleagues kind of set out to do a 1,200 patient trial on the prospective surveillance model of care? Can you talk a little bit about that? And Dr. Shah, I'll start with you.
Sure. I mean, I think, as a breast cancer oncologist and a radiation oncologist, I had gotten used through my training in my early years of practice of seeing women who had lymphedema and symptomatic lymphedema and really not having a lot to offer them. And I think the thought process was when you got to that, stage 2 and on, you really were in kind of crisis mode, trying to just manage symptoms and prevent hospitalizations, but you weren't doing much more than just, trying to prevent more water from coming to the boat than anything. And I think when we think about disease management in general, we've learned that an ounce of prevention is worth a pound of cure. And so what we've started doing is saying, well, there's got to be something between no lymphedema and irreversible lymphedema. And the data had borne that out. And so that's really the genesis of the trial was, 1, do we have a technique that allows us to pick that up early? And then 2, does picking it up early and intervening in a non-interventional way bend that curve? And that was really the thought process behind the trial.
Mm-hmm. And Louise, when you think about the data that existed at that time, one of the things we talked about that the idea of early detection and intervention was pretty well established that it's helpful. But what detection method you should use? I mean, what did the clinical study or clinical evidence landscape look like at that time, and why undertake a trial like PREVENT?
I guess for me, working in lymphedema for over 30 years, I've seen a big change in practice, just like we have in breast cancer management as well. But lymphedema has often been the second cousin to breast cancer management. So the advances in breast cancer management showed us that we were changing our surgical radiation chemotherapy management for breast cancer. Lymphedema was something there, as we know, that if you're that 1 in 5 individuals who get lymphedema, it impacts your life significantly, not just physically, but functionally, psychologically, financially, so having to seek treatment. And so for those individuals, lymphedema was a big thing. When I was introduced to the technology and the research that we could try to reduce someone's risk of developing lymphedema, then I was all in. And we were trialing and using this technology before the PREVENT study came. And like Chirag said, there was some emerging research. Nicole Stout and other colleagues in the US were doing research in this area, but we needed to do a large randomized controlled trial to really show that this was the way to go. And I know from my own patients, for some who may not have been offered this model of care in the early days, they were feeling really almost ripped off or upset that they didn't have access to this model of care. And I guess I still promote now, it's my vision that everyone at risk of lymphedema has access to this model of care that we're talking about today. So the PREVENT trial coming at the time it did was the perfect timing to really take us to the next level in preventing lymphedema.
Thank you. And, let's start talking about the PREVENT trial a little bit. Can you walk the audience through what was the goal? What was the primary purpose of the PREVENT trial?
Sure. So the PREVENT trial was really designed to determine if subclinical detection of extracellular fluid via bioimpedance with the early intervention using the compression garment reduced the rate of progression to complex decongestive physiotherapy, which we used as a surrogate for chronic lymphedema, as compared to standard tape volume measurements in conjunction with a garment given for intervention as well. And I think there's a couple things that unpackage here. I think the first is this wasn't just a, whatever tape measurement. This was a very rigorous, this is gold standard tape measurement. You can see the board. We had fidelity checks. This is like the best tape measurement you can do against bioimpedance. And both arms did get intervention. So people often ask me, why is it that a trial looking at diagnostics could look at a long-term outcome like the development of chronic lymphedema? And the whole idea was, if you can have a diagnostic that picks up something earlier and you give the same intervention at 2 different points on the lymphedema development curve, the idea is that you're preventing chronic lymphedema by using a diagnostic that's more sensitive and allowing for earlier detection. And the figure on the right shows kind of a curve that we see for someone who may trigger, someone who's kind of gotten measurements over the course of a period of time, who gets into that red zone, and who then has a compression garment and then returns kind of back towards a normal standard.
Mm-hmm. So, I mean, this trial in the end is really trying to evaluate these 2 detection methods. And of course, we're trying to test bioimpedance against tape measure. Why was tape measure chosen over another detection method? Louise, do you have any thoughts on that?
I guess tape measure was it's a badge of honor of being a lymphedema therapist. The tape measure is generally the clinical tool that's cheap, it's cost effective, it's easy to use, but there are many issues in relation to the tape measure in regards to measurement error and getting a consistent amount of tension with it, which is, as Chirag said, the way we conducted this trial using the tape measure, we had extensive training, we had inter-rater reliability testing to ensure that we were getting a consistent measurement to compare the bioimpedance device.
Yeah, that's wonderful. Thank you. So I'm going to switch over here to protocol. So, and we actually have, when we talk about implementing this model of care in practice, we get a lot of questions around different aspects of this protocol. And so I think it would be beneficial to spend a little bit of time talking about it. And we're going to go from left to right. So let's start with who is involved, right? Which patients were included? So you talk, and Louise, why don't we start with you? Which patients were included in the PREVENT trial, and how were those inclusion criteria determined?
So we included the higher risk women to develop lymphedema. So we looked at women who were having surgery, chemotherapy and radiotherapy, and we identified those women from their local treatment centre. So they were referred in or invited into the study. We looked at their lymph node status and we categorised them as sentinel node biopsy and axillary lymph node dissection. And we looked at the number of nodes they had. And I guess one of the things with this is looking at risk stratification. And we were really looking at women who are at the higher risk of developing lymphedema. Chirag, do you want to say more about that?
No, I mean, I think I agree with that. We were trying to pick out the right patients for who this is needed for, while also being conservative and not missing patients, as you alluded to previously. The only 2 points I would say is the LDEX testing. We modified that based on emerging data from a change of 10 to a change of 6.5 and back validated that against all patients. The other question I sometimes get asked about is that 10% change and why those patients who had a 10% change weren't included. The reason is it was felt that was actually clinical lymphedema when you get over a 10% change. And so we felt that we didn't have appropriate equipoise to leave those patients in the study, and we referred them automatically to CDP. But that being said, we'll go to the results. The number of patients in each of the arms that did that were actually well balanced between the two. So not something that impacted the outcomes.
Okay, so that's interesting. So 1,200 patients enrolled, trying to make sure you get patients that are high enough risk for lymphedema at 10 sites. Now, when the patients completed their surgical treatment for breast cancer, you had a baseline and then you had follow-up. So the follow-up time points are there on the bottom of the slide, the 3, 6, 12, 15, 18, 21, 24, 30, and 36 months. And the 15 and 21 months visits were at the investigator discretion. Dr. Shah, why was there a baseline and how are these follow-up time points selected?
Yeah, so I mean, I think we wanted a baseline up front to make sure that there wasn't someone who already had, lymphedema, first of all. But also, I mean, as a good practice, it's ideal to have a baseline, though you can do this without a baseline. In terms of the follow-up, we were trying to pick time points where the patients were at the highest risk of developing lymphedema, while also not putting them through too many onerous visits. So, usually, 3 visits within the first year at 3, 6, and 12 months, and then the 15 and 21 were optional, so at least the 18 and 24, and then 30 and 36. Most data says that the highest risk of developing lymphedema is within the first 18 to 24 months, though some patients can have late development, so that's why we follow them to 3 years as well.
Thank you. And Louise, why were the 15 and 21-month visits optional or at the investigator discretion?
Sure, Joanne. And can I just mention that you'll notice there we don't have a 9-month follow-up period, and that was also decided on by the team because at the 9-month mark, often women are going through their chemotherapy treatment, and we know that the taxane chemotherapy may increase their extracellular fluid levels. So we didn't want to have to exclude those women when potentially those readings would have come down. The 15 and 21 months were optional visits, although incredibly we had significant amount of women who attended for those appointments, but we were just trying to reduce the burden of individuals coming back for monitoring at those periods of time.
What would you say to those in the audience looking to implement this model of care in practice? Would you encourage them to try and get all those time points, or do you think they can consider 15 and 21 months optional as well?
I very much on looking at risk stratifying for your patient, so that if someone's at high risk, you want more measurements and at the 3-monthly mark. And usually at that time, they potentially may still be going through treatment at that 12 to 15 month. They may still be having some treatment. Ideally, the more information you get, the richer the data for you to be able to provide clinical feedback and clinical information. And it does depend where the individual woman's up to in their life journey. If they've spent time off work going through their breast cancer treatment, they may find it hard to get more time off to come for these regular appointments. But if they are able to, then it gives us further information to be able to assess their condition and monitor them.
Thank you. And so when we look at the follow-up time points, of course, the patients are getting monitored. Tell me about the the 1-to-1 randomization. The patient selected either to go into the LDEX arm or to go in the tape measure arm. So if a patient is being monitored with LDEX, you started to allude to this, Dr. Shah, that the original protocol was a change of 10 or more from baseline, and that was modified to 6.5 from baseline about a year into the trial. So why was the 6.5 change in LDEX selected as the trigger?
Yeah, so we're really looking at a change of going from 2 to 3 standard deviations. And what this was based on is a set of data saying that you're going to have increased sensitivity when you went from 10 to 6.5. And so we reviewed the literature, we reviewed with the IRB, and the decision was made to maintain equipoise for the trial, and also to follow the emerging data to adjust it to 6.5 and then go from there. So it was really data driven and tried to keep the trial as modern and up to date as possible at the time.
Mm-hmm. And then Louise, on the tape measure side, the trigger for subclinical lymphedema is the 5 to 10% increase in arm volume from baseline. How was that selected?
So as Chirag already said, that 10% volume difference is usually identified as your clinical lymphedema diagnosis. So we knew that if we were trying to identify subclinical lymphedema, which is what we're finding with the LDEX outcome, then we need to go under 10%. But we've also got to remember that there's normal dominance factors in a person's arm that you could have up to 3% or so difference in an arm volume due to just dominant factor. So we selected the greater than 5 and less than 10% as the best volume difference using the tape measure to pick up that subclinical change.
Okay, thank you. So then the patients were monitored with one of the 2 methods, and if they triggered for subclinical lymphedema, Then they received intervention. Louise, can you talk a little bit about the intervention they received and how that was selected for the trial?
Sure. So they were measured for a compression garment, an arm sleeve and a gauntlet, a 20 to 30 millimeter level of compression. And they were fitted with that by the research team, taken measurements. If they didn't fit into a ready to wear garment, they were then measured for a custom made garment. And the intervention phase was wearing the sleeve and gauntlet for 12 hours a day for 28 days. And that was the intervention period that then they would come back and be reviewed after that 28 days. And also we asked the patient to keep a diary of when they wore the sleeve, so we could just confirm that they were wearing it for the allocated times that we asked them to.
Thank you. And how was that compression intervention selected? Like, what was the rationale for selecting that?
So that was really based on previous research that compressions plus early detection and compression gives better outcomes, but this study has then gone on to prove that even further with data. And over the last 10 years, there's been significant data showing the benefits of early detection and early intervention, and compression is really the tool that we know helps to pump that lymphatic fluid. We want the individual, we're not saying when they've got subclinical lymphedema that this is something you've got for the rest of your life. We're doing it as an early intervention, and that's why the compression class is important. Sometimes I've had therapists say to me, oh, well, I can't see any swelling, then maybe we should put them in a lower class of compression. But the research has showed us in all the studies that they've used a 20 to 30 millimeter of mercury compression, and that's why we're following that protocol.
Yeah, thank you. Now, so a patient triggers, they undergo intervention, wear the compression garments for 4 weeks, 12 hours a day. Then what happens? What happens to that patient after that 4-week period, Dr. Shah?
Yeah, after that, we continue to follow them. And this was, again, a part of the discussion of how do you follow these patients? And, in a perfect world in my clinical practice outside of a trial, I would probably put them back on, LDEX follow-up. But, when you're trial comparing two upfront surveillance strategies, the same interventions, we had to follow everyone in the same way so that it was a fair comparison after the fact. And so in the study here, we actually just measured everyone with tape measurement for consistency to allow the trial to kind of have that balance between the two randomized arms. So we followed them with tape measure as long as they stayed under 10%. We followed them for up to 3 years. If they ever exceeded 10% or more, they progressed to CDP.
So every patient in the trial, whether they trigger for subclinical lymphedema and receive intervention or not, can either exit the trial by reaching a 3-year follow-up without a volume change of 10% or more, or having that volume change of 10% or more, in which case they would be referred for CDP as an endpoint of the trial.
Correct.
Wonderful, thank you. And if the audience has any questions about the protocol or anything else we're discussing, don't hesitate to submit a question with the Q&A icon on the screen. So thank you. I mean, clearly this is a well thought through trial design that, the two of you plus the expert group that you had to work through put together. So let's talk about the results. And just really quickly here, we have an overview of the 8 manuscripts generated from the PREVENT trial. Louise, would you walk through each of these 8 manuscripts? Just, we're going to dig into the details. You don't have to go to the details of every one, but just a high level, what the key publications were and some of the rationale behind it.
Yeah, so it's really nice to see that those 8 publications there in one table, because that's a lot of hard work and a few grey hairs, I think. I've got grey hairs. I'm not sure about you, Chirag, grey hairs. But what this shows is a story. And from the top of the screen, we've got the primary endpoints for the study. So we had primary outcomes and secondary outcomes, and they have both now been published in those first top 2 publications. We then looked over the study period. We were able to sub-analyze some data as the study was progressing to try to educate and inform health professionals of what was happening. We had interim results of the study midway through to help us guide, are we on the right track here? Do we continue the study? We looked at risk factors for breast cancer related lymphedema. We looked at the extent of radiation treatment in that radiation analysis paper in 2020 that really looked at regional node radiation as being a risk factor. The REAIM framework paper was one I was involved in, where we were really looking at an implementation. So it's okay to have the results of this good research, but how do we actually implement it into clinical practice? And that's something that I'm pretty passionate about, that it's okay to have the results. But if you're a therapist sitting there, or a medical practitioner, a nurse sitting there thinking, that all sounds great, but how do we change practice in our clinical care? And we'll talk more about that. So really, and we've talked about the change from the 10 LDEX points to the 6.5 to support the research that was happening at that time. So there is a story, and you know, we've still got more data to be actually able to publish from these results.
Yeah, and we're looking forward to that. And thank you, Louise, for walking through it. We're going to go into some of the details of some of these publications. But first, I want to notify the audience that you can access all of these papers online, and an easy place to find links is on ImpediMed's website. If you go to ImpediMed's website, you'll see in the main navigation a link to the Prevent Trial page. And at the bottom of that page, you can find links to the manuscripts for all 8 of these papers. So feel free to visit and pull them up as you see fit. Let's dive into some of the data. Dr. Shah, would you get us kicked off here a little bit about the purpose and what we learned from the interim analysis published in May 2019?
Yeah, so, the interim analysis was a planned analysis to really see where the data was, where we're heading, understanding that we were going to be limited in terms of statistical power, given that we didn't have enough events. So we did this interim analysis following up through 1 year with 50% of patients enrolled. So really, not the huge power events, but wanted to see where we were with things. And what we saw was that a lower progression to chronic lymphedema using CDP as that surrogate with bioimpedance and LDEX as compared to tape measure. So it was about 14.7% versus 4.9%. But given that it was still a small number of overall, the P wasn't significant, but the clinical outcome was at a 10% reduction. The other thing we saw was that there were significantly fewer triggers, and therefore interventions with LDEX than tape measure. And one of the questions was, well, how does this work? How can it be that tape measure is triggering more if LDEX is more sensitive? And I think that goes to the question of, well, you have to make the assumption that every trigger is a true trigger. And I think with LDEX, the data has shown that to be much more the case. But with tape measure, what you see is even with a gold standard tape measurement, technique, you're getting a lot of false positives, a lot of red herrings. And so, yes, there's a lot of triggers happening, but they're not very meaningful triggers, and those patients may not truly be at risk of developing chronic lymphedema. And so this was the interim analysis, was published in the Annals of Surgical Oncology, and really kind of laid the table for the final analysis, which was published earlier this year.
Thank you, Dr. Shah. And we're getting some questions through the Q&A that really have a lot to do with translating the protocol and these results into practice. So we're going to have once we go through some of these results, we're going to be talking about that. So I'll be sure to bring up these questions then. In the meantime, Louise, do you have anything to add or anything else you'd like to say about the interim analysis?
No, it just encouraged us, I guess, to keep going with the study and to continue recruiting women. And I know from our site here in Australia, we actually didn't have a problem recruiting women to the study. That, their surgeons encouraged them to be involved, and they actually really liked having that contact with our research team. And in fact, by the end of 3 years, some of them were a little bit disappointed that they weren't continuing monitoring with us because they felt reassured by that contact with the study team.
That's wonderful. I'm so happy that those patients benefited from participation. So let's talk about the REAIM framework. And Louise, I'll love to ask you to talk a little bit about this study.
Yeah, so as I mentioned, Joanne, the implementation is really where we're up to at the moment. So we've got the good solid data to show that this model of care and using bioimpedance spectroscopy is the gold standard of treatment. But the challenge can be, how do we implement it? And I use an example of a site here that we had contact with, where you had the surgeon and the medical oncologist in one part of the hospital, in the cancer centre, and you had the physiotherapy lymphedema clinic in another part of the hospital, but, you know, a significant walk away. And prior to us implementing this study, the site was not doing baseline bioimpedance measurements or any sort of screening for lymphedema until someone really developed a problem with lymphedema or needed some musculoskeletal work for rehab following surgery. And what we found by showing the results in this study, that we were able to see as a research team these women before surgery, and we were able to get them to have their measurements before surgery. And so that actually then was able to change practice for that site, in that now it's standard of care that all individuals diagnosed with breast cancer at that site get immediate referral to have the baseline bioimpedance readings taken. And that's what we're wanting to have. Ideally, baseline readings at the time of an individual's diagnosis before they have any neoadjuvant chemotherapy or surgery. That would be the ideal. But as Chirag alluded to, we don't always, it's sometimes not possible to do that. And that doesn't mean, well, if you don't get the baseline, you can't be involved in the study. But this paper published in Supportive Care and Cancer Care in June 2020 really just highlighted looking at the REAIM framework of implementation science, that we were able to educate health professionals in how to implement this model of care, which I think still needs a little bit of work, but hopefully we're getting there.
And that's wonderful. So you have trial sites that weren't doing this, participated in the trial, now continue to offer this to their patients.
Correct.
That's what a fantastic vote of confidence.
And I would think too, Joanne, the key things from this is identifying risk stratifying your patients, and being able to have a referral pathway in place so that wherever the measurement is taken, it doesn't have to be a lymphedema therapist. It could be, you know, a health professional on the multidisciplinary breast cancer team that takes the measurement. But you need to have a pathway in place so that if someone triggers the need for early intervention, that early intervention happens in a timely manner.
Absolutely. Thank you. Now, Dr. Shah, in October 2020, there was analysis published looking at the impact of radiation. Would you talk a little bit about this publication?
Yeah, so as a radiation oncologist, I'm routinely blamed for causing lymphedema, and unfortunately, this paper confirmed that that's probably the case. And you know what it really showed is that first of all, the more aggressive you are with your axillary therapies, the higher risk of lymphedema. So confirming something that we kind of knew, but in a large-scale way, showing that more axillary surgery, more axillary radiation, more extensive axillary radiation is associated with lymphedema. But I think the other thing that's interesting is we saw when we broke these risk factors up, and it's interesting when you look at the triggers, back to the previous point, when you look at the triggers with tape measure, all of the different groups that we looked at in this paper had almost identical rates of triggering with tape measure, meaning there was no discrimination, you know, and it was just basically you're not sure what you're getting. Whereas when you had the bioimpedance patients that were looked at, as you increased axillary therapies, you saw a clear increase in trigger, showing kind of a clear sensitivity to picking up that risk associated with increasing axillary therapy. So, you know, really that's what it confirmed, I think, for us, is that one, more axillary treatment, higher risk of developing. Number two, bioimpedance can kind of discriminate that risk of axillary therapy where tape measure was unable to.
Thank you, Dr. Shah. And then, you know, you both have brought up risk factors, and Louise, you were lead author on this paper evaluating BCRL risk factors from the study. Would you mind reviewing this manuscript for us?
Sure. So this really confirmed what is around and published in other data. I don't think we found anything strikingly different with our cohort of women. And I think that's a positive thing to show that the women in both groups of tape measure and bioimpedance spectroscopy were a cohort of women similar to other populations around the world treated for breast cancer. And the confirmed high risk factors for lymphedema was someone having an axillary lymph node dissection, someone having taxane-based chemotherapy, regional node irradiation, as Chirag had said, and obesity, the BMI greater than 30. But that BMI of greater than 30 is at an individual's diagnosis time. So it's not if they've put on 10 kilos down the track, it's at their BMI at time of diagnosis. Interestingly though, because we had patients from rural settings, this study showed that there was an increased risk of breast cancer related lymphedema for patients living in rural areas. And I think that's something that we need to do some more thinking and work about in our education and in monitoring programs, that if someone's unable to come to their large treatment centre to be monitored, how might we be looking at still including them in a monitoring program, but perhaps alternative ways of monitoring them, in between times when they're coming to a large clinical setting. And also we collected information about air travel, which is a common myth and a common discussion item for individuals traveling. I know for those treated in Australia, everybody wants to travel to the UK or to the US after they finish their breast cancer treatment. So we had a lot of air travel data, and we recorded the number of flights and whether people wore compression garments, which is a known preventative sort of strategy. And what we actually found was there was no increased risk for those traveling on an air travel during this study for lymphedema. So that was actually a positive thing. So that was published in the journal Cancer earlier this year.
Thank you, Louise. And now we'll talk about the primary endpoint analysis. So Dr. Shah, would you talk a little bit about the primary endpoint results published back in January?
Sure. So, this was when we took the patients and we got them to 3 years. And we obviously had the events we were hoping for to help power the study. And what we showed was what we hoped to show, which is that there was significantly lower progression to chronic lymphedema with using bioimpedance and LDEX with early intervention compared to tape measure and earlier intervention. And actually the difference grew from the interim analysis from about 10% to about 11.5, 12%, and it was statistically significant. We confirmed that less triggers were needed as well, so that we were seeing more sensitivity with LDEX rather than these spurious false positives with tape measurement. So overall, a nearly 11.5% reduction and nearly 60% relative reduction in the risk of chronic lymphedema. So going from 1 in 5 patients to less than 1 in 10. So a pretty big clinical win.
And then, of course, there was the risk factor analysis that accompanied the primary endpoint results. Would you mind talking about this one a little bit?
Sure. As a clinical trialist, this is like not something you ever expect to see. And when you do, you kind of smile. So, just given that as you start looking at, subsets of patients, there's always the risk of a spurious result because you have fewer events that can kind of cause something to actually show significance. But what this shows is no matter how you split up the population, every one of those patients benefited. So high BMI patients, advanced stage, mastectomy, dissection, chemo, radiation, regional radiation, high risk. And if you look at the odds ratios, I mean, this is amazingly impressive. So, all of them are not only statistically significant, as you can see from the confidence intervals all staying short of the one line, but they're all within a range of about 0.13, 0.14. I mean, most of them are on 0.35, 0.36. The highest you see is 0.39, the lowest you see is 0.23. So kind of impressive just how consistent these results are. So, people ask me which patients, I say, well, basically any patient that was eligible should be considered because look at this plot. There wasn't a patient subset that didn't benefit.
Thank you. And Louise, do you have anything to add?
No, I think this is really nice to see it there. And it just is hopeful, I think. It brings a lot of hope for those diagnosed with breast cancer in today's world to know that if they can be part of this model of care, prospective surveillance, so screening and early intervention, that the odds are pretty good to help reduce the risk of developing clinical lymphedema.
Thank you. I'm just going to back up one slide. We went through many of the key manuscripts from the trial. And as you mentioned, Louise, there's likely more to come. But I just wanted to take a moment and ask each of you, when you think about this trial as a whole, and all of the research and kind of insights it's generated. Did anything surprise you along the way? So is there anything that you look back and you say, wow, I didn't expect that?
I was impressed that we accrued as quickly as we did. You always worry in a 1,000+ patient study, are you going to get to the end of accrual? But to Louise's point, patients wanted to do this. Patients wanted to be involved in their survivorship and follow-up. They wanted to be proactive in trying to detect lymphedema early and intervene. So just the fact that we accrued so quickly and were able to get this study, from conceptualization to final paper in under 10 years is pretty impressive.
Yeah, I mean, you're involved in a lot of clinical research. I mean, getting patients to consent to a 3-year follow-up, that has to be, that can't be easy.
Yeah, it's not always easy. And, in this case, I think patients were very motivated, which helped. They want to be involved in this and they want to prevent this when possible.
Thank you.
And I
What
know
about you,
for
Louise?
us that in Australia, lymphedema was recently identified as the top information need of breast cancer survivors. So even though we've talked that we've come a long way over many years of improved surgery, improved medical treatment for breast cancer and reducing risks of lymphedema, there's so many myths and misinformation out there of people knowing someone who's had lymphedema and the big fat swollen arm from years gone by. They get very anxious about it. And so I think this study showed that women were interested to be involved. They committed to the time and they loved having their readings done. They loved having their measurements done. They loved having that reassurance that what they were doing helped them to reduce their risk of getting lymphedema. And it was quite empowering, I guess, for the women, which is what we want. We want to empower our women. We want to give them information. We want to see over time, are there any changes? And I think LDEX is a beautiful way of telling a story. And I've got patients who, I write on their little piece of paper, their LDEX reading, and they bring that in each time. And if they ever forget the little card that I write on, they say, oh, I'm really sorry, I forgot to bring the card. It doesn't matter to me. I've got all their readings stored in the SOZO hub. But for them, it's giving them that visual information, I'm okay. Or if it's slightly up, maybe I need to do a bit more exercise. Or if it's going down, well, that's good. It's telling me that I'm on the right path. And that's what we want. We want to educate and empower our women to feel in control.
Yeah, that's wonderful that your patients are being empowered. I mean, what kind of objections do you get? I mean, have either of you been challenged by other clinicians on this research? And what's coming across and what do you say when you get challenged?
I can't say that I get challenged very often. I mean, it's part of our clinic. If for anyone who was on the call right when we were starting, that video is in my clinic. And you can see, I actually share my clinic with my breast surgical colleagues, my medical oncology colleagues, my breast radiology colleagues, genetics. So it's in our vitals room. It's where we check our weights and our heights and everything. So I actually haven't gotten any real pushback from colleagues. They've just been excited and supportive and wanted to be a part of it.
Thank you. Go ahead, Louise.
I was just going to say the same for me. I bring people, you want to bring people on board. And, it's a bit of a no-brainer in my mind that this is a test that's quick and easy and empowers individuals. And if it reduces them developing this chronic lymphedema that I used to have to bandage and manage with people forever, this is a really good outcome.
So let's talk about that a little bit more, about that implementation. I'm just going to fast forward here to, really talking about the impact on patient care. The quote that you see in the blue at the top of this slide is from a survey that ImpediMed ran with secondary lymphedema patients that are members of the Lymphatic Education Research Network. With cancer survivors with lymphedema, really talking about the struggle that they have with living it, which speaks to what both of you have brought up, which is patients were very willing and excited to participate in this study, even a study with 3-year follow-up, and appreciated the extra attention that they were getting. So we're getting, as we talk about kind of the difference between allowing patients to report symptoms at the point where they're chronic and now they're facing chronic management versus setting up a proactive mechanism for early detection and intervention using LDEX. We're getting some questions about protocol, and I also I have some questions here for you as well. So going back to the protocol, we got a question which brand of compression garments were used in the trial? And I'd love you to kind of talk about that a little bit, Louise, like which brand, and then what role do you think brand preference plays as clinicians are trying to, deliver compression intervention to these patients?
Thanks, Joanne. For the PREVENT study itself, we had the compression garments supplied by Medi. So we use Medi compression garments, the Medi Harmony arm sleeve and gauntlet, or the Medi Esprit Medivan ready to wear flat knit garments. And so we're very grateful to have had that support throughout the whole time of the study, and we were able to access those garments very promptly in order to be able to fit the women straight away when they were identified as needing the intervention phase. I guess for those of you who may not have access to Medi garments, every single compression garment company in lymphedema does have an early intervention garment. So you're looking at the 20 to 30 millimeters of compression, arm sleeve plus gauntlet to start with, because you don't want to put just an arm sleeve on someone and cause some pooling of fluid in the hand or cause hand edema. So the protocol that this study and previous studies showed wore both. Certainly the individual may be able to remove the hand piece down the track, but as part of the study, they did have the hand piece as well. I guess my biggest recommendation to all therapists, health professionals fitting compression garments is that it needs to fit appropriately. And what I mean by that is the various garment companies supplying these garments have different size ranges, and you need to be able to fit someone into the appropriate garment, not squeeze them into something that potentially is going to cause problems. So what I mean by that is that someone might have a really small wrist, but a big upper arm. We call them here the tuck shop arms of some of our ladies, so a wider, larger upper arm, but a very small wrist. If you just go straight by the sizing charts of compression garment companies, you may not find one that's got an extra wide upper arm. And so you may need to go custom made, but it's worthwhile looking at other companies because they may have other options. So just be aware, you need to fit the garment according to the individual's measures, not just squeeze them in because it's cheaper or a quicker option.
Thank you, Louise. And we're getting some more great questions through Q&A. If anyone has questions, feel free to submit them. We have a question about the protocol and baselines. And in all honesty, that the baseline measurement comes up as a question for the ImpediMed team quite a bit. So tell me a little bit about preoperative baseline. Was that prior to neoadjuvant chemotherapy? If someone is trying to implement this in the real world, when should they really try and get that baseline measurement in an ideal state? Dr. Shah, would you like to go?
Sure. So, I mean, I'll say in the real world, I try to get it when they come in for their initial diagnosis. Sometimes we don't know if they're going to get neoadjuvant therapy or go to surgery. We may be waiting for staging, whatever it may be. But I typically push for it to be done as part of their initial kind of first visit. I think to one of the questions point, we do know that some chemotherapies can be associated with the development of lymphedema. So for that reason, I like to do it before they have any therapies and then follow them at that point. So that's kind of what we do.
Mm-hmm. And then what happens if there is no pre-treatment baseline? You know, many of our users may not end up seeing the patient until after their cancer treatment has started. You know, Louise, what can people do in the real world if there is no pre-treatment baseline?
Yeah, and that does happen. And I think it's to not think I'll put them in this model of care if that's the case. So I agree with Chirag, ideally pre-treatment measurement before chemotherapy or before surgery. But if you don't have that, then taking the baseline of when's the first time you're seeing them, hopefully it's within that normal range, the green area on the LDEX reading. We do say that if the reading's close to an LDEX of 7, then that could be indicative of subclinical lymphedema. But if that happens in my clinical practice and I've just seen someone and they're not reporting any symptoms at all, and no signs or symptoms of any sort of swelling or heaviness or aching, then I might actually get them to come back, say 4 to 6 weeks later, rather than wait the whole 3 months of monitoring if I'm unsure whether it may be subclinical lymphedema or not. So there's a little bit of a grey area that you take that first measurement and then you want to monitor using that as the baseline, but having a good understanding and insight to what else is going on for them at the time. Are they just a few weeks post-surgery? Are they in the middle of chemotherapy with taxane or in the middle of radiation when they're coming to see you and you want to take this measurement? You've got to consider those other factors which may potentially have an impact to that reading.
Okay, thank you. And when we talk about the protocol, Dr. Shah, there were 1,200 patients. We have a question about male and female incidence of lymphedema. But were there any men enrolled in this study?
I don't believe there were any men in this study. That being said, I think the risk of lymphedema is more predicated upon the therapies and the clinical factors less than gender. So I treat them the same if it's a male, locally advanced male breast cancer. I treat them the same in my practice as a female locally advanced breast cancer.
Mm-hmm. And if you look at that protocol overall, we got a really interesting question, and you might even consider this the protocol running through the trial. And I'd love to hear on both of your own experiences implementing this in practice. But what were the obstacles you faced? What obstacles did you face in running this trial?
I think to Louise's point, once we kind of made it known to clinicians and patients, it was actually pretty easy to get them in. I think the biggest thing was making sure you had good fidelity of your tape measurement. Actually Dr. Ridner came and did annual fidelity checks at the sites to make sure we were all staying kind of part of the course.
Mm-hmm. And one of the questions we get, and I'm wondering what happened in the trial, let's say a patient missed the follow-up. So let's say they missed their 12-month visit. What happens then? What do you do then?
So as part of the protocol, we had a time frame in place to be able to do that 12-month measurement. So many days after when it was scheduled, it was all on a spreadsheet that our staff had to follow. If they missed that, and sometimes there were legitimate reasons why they missed that or were unable to come to that appointment, then they were able to come to the next routine appointment. If they did miss 2 appointments, then they were really considered have left or withdrawn from the study. But that was very few people in the whole study out of the 1,200 women.
And what do you do in real world practice? If a patient misses a follow-up visit, how do you take that into account? Are they done? Do you keep following them? What's your approach?
I think from my point of
view. So sorry, Louise.
No, you're right. You see them when they come. I think real world clinical practice is more challenging of getting people there than in a clinical trial, where in the clinical trial it was resourced for the research team to be contacting these individuals and to make the appointments to come for the monitoring to link in when they're coming to another medical appointment in the centre. Whereas sometimes if they're just coming in for a routine screening of LDEX, perhaps it's a little bit harder, particularly for those who have returned back to work. And, a long time down the track, they might not be coming for as many regular review appointments with their medical team. So, you see them whenever they come to you.
Sure, thank you. And interestingly, we have a follow-up question. So just really quickly, for the compression therapy, what was that? Someone asked, did they get it prior to surgery or immediately after surgery? Could you revisit a little bit again, when in the course of treatment is the compression intervention delivered to the patient?
So the intervention was provided when a woman triggered early intervention, either with the 6.5 LDEX change from baseline, or if they had a greater than 5 and less than 10% volume difference on the tape measure. So they were coming in for their regular monitoring period at those designated timeframes that we said. And if at that appointment they triggered early intervention by either the tape measure or the LDEX, they were then measured for and generally fitted on the spot on that appointment for the compression garment. If they needed the custom made, they had to wait for that to be delivered. But the intervention started for that point on for 28 days from when they had the garment.
Thank you. And we're getting a couple questions about insurance. And of course, we have viewers from the United States, we have audience from Australia, as well as other countries. And so, of course, the insurance situation is very different depending on the country. But we have a question about insurance coverage for compression garments in the study. And I will just say, once a patient is enrolled in the clinical trial, all of the therapy they receive, they don't have to pay for. So patients that were involved in the clinical trial did not have to purchase the compression garments. They were provided, as Louise said, they were provided at no cost to the patient, and that was supported by Medi. We do also have questions about insurance coverage for SOZO measurements. And because we have a broad audience, what I will do is we'll have your local ImpediMed representative follow up with you to talk specifically about insurance coverage in your location. In general, in the United States, there is a Category 1 CPT code associated with the bioimpedance test for lymphedema assessment, which is billable. And so if you have any questions about that, don't hesitate to reach out to ImpediMed and we can get you the right information you need to be successful with coding and billing in your organization. So we're going to wrap up here, and I have 2 more questions for our panelists. First is, we get a lot of questions. Now, this trial is breast cancer patients. It's unilateral arm lymphedema. That was the scope of the PREVENT trial. We get questions about, well, I see melanoma patients that are at risk of lymphedema, gynecologic cancer patients at risk of lymphedema. Do you think that this model of care applies to other cancer types as well? And Dr. Shah, I'll let you go first, and then Louise.
Sure. I think, first of all, when it comes to upper extremities, I tend to think of disruption of the axilla as disruption of the axilla, whether it's done for breast cancer, melanoma, Merkel cell, whatever it may be. So I do think that certainly that is something. And same thing with gynecologic cancers like vulvar cancers, vaginal cancers with disruption of the inguinal lymphatics. So I tend to think that disruption of lymphatics in that sense can be lumped together, though there may be not a randomized trial like PREVENT for each of those disease sites. So I think it certainly makes sense to consider.
Thank you. And Louise, what do you think?
Yeah, I would support what Chirag says. I know here in Australia, melanoma surgery, often patients are fitted with compression garments soon after surgery as a preventive for lymphedema. I think there needs to be more work in that area, but certainly I think the model that we're talking about in this study can be picked up and put in all of those cancer areas. And I think, if we also look at the other advances with the bioimpedance technology, the whole area of body composition that you can now get from just pressing the button for an LDEX reading. I think in all cancers, we can look at body composition over time, which really looks at the whole sarcopenia and nutrition, which is a part of cancer survivorship that, is very needed at the moment.
Thank you, Louise. And I think our next webinar is looking at survivorship as a whole. But we're going to wrap up here, and I just want to ask each of you for some parting wisdom. So, you were both involved in this trial from beginning until now, and have seen the evolution of our understanding of lymphedema through this trial, and as well as in your practice as well, and other research that's ongoing. And we're working with clinicians every day, looking to implement this model of care, running into their own obstacles and challenges as they try to do this to help patients. Any parting pieces of advice or wisdom that you can offer? And Louise, I'll start with you.
As health professionals, there's a lot we can do to reduce lymphedema. this PREVENT study has shown positive outcomes for using LDEX in regular monitoring, screening, and early intervention. I think we need to consider risk stratifying our patients and ongoing education with our patients to really empower them to feel in control and to take ownership that they can do something in their cancer journey.
Thank you, Louise. And Dr. Shah?
Yeah, I mean, it's been about a decade since we first thought about PREVENT, and here we are. So I think, when I look at my own practice, it's kind of like watching, your best hopes come true. It's part of our vital signs. I think the biggest thing that I've seen from colleagues, in developing this kind of program, to Louise's point, is there can be an inertia, right? That people are used to what they're doing and it's hard to make change. One of the common things I hear is, oh, it must be a lot more time or it must be more cost. And actually, so we've done some studies and even shown that it actually costs less to run a program like this than it does to have someone take tape measurements day over day. So I think that at the end of the day, we have to fight inertia and try to do what's best for our patients as they enter survivorship to help reduce the rates of lymphedema.
Oh, well said for both of you. Thank you so much, Louise and Dr. Shah. Your insights and are just so valuable in your knowledge working through this. So thank you for taking the time to meet with us. Thank you for everyone for joining. We will have this replay available for everyone registered, and it will be on our YouTube channel before the end of next week. So I hope you all have a great day and a great evening. We'll see you next time.
Thank you. Bye-bye.
Thank you.